thought I'd get started because it's going to take a really long time to introduce our speaker because of his many accomplishments. I'm Katie Cullen, and I have the honor of introducing our speaker today, who's Dr. Kelvin Lim. Let's see. Dr. Lim has a long history of success beginning in high school, where he was a stellar student at Annapolis Senior High School in Maryland and won the Betty Crocker Homemaker Award. We have some very accomplished people in the audience as well. Dr. Lim got his BA in human biology and his MD at Johns Hopkins University. He then went to Stanford to do his resident internship and residency, and that's where he started off as well as an assistant professor. Dr. Lim then went to New York in 1998 and became a research psychiatrist at the Nathan Klein Institute for Psychiatric Research Center for Advanced Brain Imaging in Orangeburg, and also had an associate professor position at NYU at that point. Dr. Lim joined us at the U of M here in 2001 and joined our faculty in Department of Psychiatry. He's been a staff physician at GREC in Minneapolis VA system since 2004. He serves as the director of the 3T services at the Center for Magnetic Resonance Research, and he is also our vice chair of research here in the Department of Psychiatry. Let's see. Dr. Lim is very involved in this CTSI. He's the director of the undergraduate and advanced research program for trainees. He has an honorary professorship with an institution in China called he's a key lab mental health program at the Chinese Academy for Sciences in Beijing. So he's an honorary professor there. One reason he often goes to China, you might have noticed he's gone for long periods of time. Let's see. Dr. Lim you probably heard of his work in neuroimaging. He's very well known in our field for his work in neuroimaging, and more recently he's been getting into the field of neuromodulation. Dr. Lim has led 2 studies at the VA looking at transcendental meditation for treatment of PTSD and also mindfulness-based stress reduction for PTSD, and recently published that work in JAMA, which I think maybe we'll hear about today. Let's see. Currently, Dr. Lim is leading a new R01 funded by NIDA, which will be looking at neural circuitry changes that signal recovery from addiction. Please join me in welcoming Dr. Kelvin Lim.
Are you tired now?
I had to cut myself off.
Thank you. So thank you for that introduction. So you got the Betty Crocker Homemaker Award. Okay, good. Because I can't even remember Dr. Cullen was asking me what the questions were on the exam, and I said things I could remember about it was there was a lot of home finance on it, and there was a lot of nutrition types of questions on it. And so, yeah. What's that? Yours was an honorary one? Okay.
I got the award. I got the trophy.
That's good. That's important. That's important.
Sorry, I just forgot to announce that Dr. Lim got the 2014 CTSI Mentor of the Year award last year, which was, I wanted to make sure to highlight. Thank you.
Okay. Are we done with that part now? Should we move on at that stage? Okay, thanks. Thanks. Okay, so I'm supposed to do disclosures, right? Okay. So I'm kind of disappointed to say I have no financial disclosures. I just have not been savvy enough to sort that piece out. I will not be discussing any off-label use or investigational use in my presentation. I have research support from the VA, NIH, and also the Defense Veterans Brain Injury Center. What's missing from my disclosure? What would you want to know if someone's giving a presentation to you? What's their connection with what is being studied, right? So in the spirit of full disclosure, okay, I want to disclose that since 1981, when I was in medical school, I learned how to meditate. I learned how to do transcendental meditation in April of 1981, and I've been practicing that twice a day since 1981. So I just want to share that just in case that influences your interpretation of what I talk about today. Okay? Anyway, so main points for this presentation, and this is somewhat of a VA-focused presentation because this is a study I'm going to tell you about that we did at the VA, which I'll tell you a little more, is quite interested in the issue about PTSD. But these are the main points I want to make about it. One is that PTSD in many veterans is a chronic condition and really very challenging to treat. We have evidence-based therapies available at the VA, mainly tied around exposure therapy, but not everyone can tolerate it, and we'll talk a little bit more about that aspect. And I want to make points about that there are, just like there are different psychotherapies, there are many different types of meditation, and we'll try and discuss what are the different cognitive processes, goals, and actual unique brain effects that come with those. And I'll describe to you the results from our MBSR, our Mindfulness-Based Stress Reduction clinical trial in PTSD. I'll give you a little history about how we got to, we had the opportunity to do the study, and also how it compares with other standard evidence-based therapies. So that's our roadmap for today. So, post-traumatic stress disorder. Many of you, I'm sure all of you are familiar with what this is. You know, a debilitating psychiatric disorder arising from exposure to a traumatic event that involved actual or threatened death or serious injury. Was that something? That wasn't me, was it? Okay. And just to remind ourselves about the clinical symptoms of PTSD, kind of the main three core ones, is this re-experiencing piece, which involves basically the recollection or re-experiencing of the event. Could be in various forms, whether it's nightmares, flashbacks, and kind of connected with this re-experiencing comes with an avoidance, and in a sense to try avoid triggers that might bring on these, for example, these flashbacks, and this can be very debilitating because we all know patients who just basically never leave their houses anymore, right? And then there's also the hyperarousal, hypervigilance, where people are just very kind of over alert, respond to stimuli in very dramatic ways, and it also ties into other self-destructive behavior. So these are sort of the core set of symptoms we're talking about in PTSD. So from the VA perspective, and I know we have people in the audience today who are interested in PTSD aspects, and I think I hope this can generalize to civilian types of things as well too. Let's talk about the VA challenges. From the VA challenges, as many as you know, PTSD and mild TBI are the signature injuries of the OEF and OIF conflicts. These are the Operation Enduring Freedom and also the Afghanistan effort. Out of estimated 1.8 million service members who have served in these conflicts, it's estimated between 10 to 18% are estimated to have PTSD. Okay. And one of the challenges that you may have read in the press is about the issue is how many service members, particularly active service members, are willing to actually admit or seek treatment. And the problem that's been a big cultural issue within the military that the military has been dealing with. There's also a significant comorbidity aspect because, as I mentioned earlier, many of our service people have exposure to basically mild TBI, for example, blast injuries, that type of thing. And also, there's a lot of comorbid depression, anxiety, and also a lot of substance abuse that ties in with this, which clearly complicates treatment, not only in terms of the carrying out of the treatment, but also people actually seeking treatment. There's high rates of chronicity, and with chronicity comes long-term impairment in terms of interpersonal, occupational, and social functioning, which is, as we know, is very, very detrimental. And this leads to clearly poor quality of life. So there was an Institute of Medicine report that was done at the request of the VA, and to examine what are the effective therapies for PTSD. And they report there's evidence for exposure therapies, no consensus on meds, and number 4, need for more specific research in the treatment of PTSD in veterans. As I mentioned earlier, there are current treatments that are considered evidence-based therapies within the VA are tied with exposure therapy. And we'll say a little bit more about that. On medications, there really isn't much strong evidence base at this time, and yet medications are used a lot. But the evidence base currently is really strongest for SSRIs. So many of you are familiar with aspects of exposure therapy. It's a behavior therapy. We use across anxiety disorders, and it has a preclinical basis in terms of fear extinction work that has been done in rodents. And on the clinical side, it involves exposing the patient to the feared object or context that is relevant to the trauma in a safe setting. How many, in your estimation, are people keen on doing this? Patients keen on doing this? Not so much? Why is that? It's kind of scary, you know, other things like that. I remember I was interviewing one of our patients in a study, and he was very outspoken. And I said, "So, have you've been taking care of the VA?" I said, "Have you done any of the exposure therapies?" And he looked at me, and he was just being frank. He said, "There is no effing way that I'm going to do that. I'm trying to forget that stuff, not remind myself of it." So that was kind of one of the. So this is one of the issues in terms of the exposure therapy piece. And the two main exposure therapies that are done within the VA are prolonged exposure and cognitive processing therapy. So the question is, if we have the exposure therapies, do we need other treatments? Do we need other treatment approaches? These treatments that we do have do not have universal effectiveness. Okay, and what are the issues? It turns out the data suggests that between 20 to 50% of people, and these are veterans, this is in a veteran setting, 20 to 50% of people do not complete or do not benefit from exposure therapy. A big issue is it's about a 40% dropout rate. Okay, so you have 8 sessions, they drop out before they complete the therapy specs. And this raises other important issues. If you tried a therapy that the VA says should work and you are unable to complete it, what are the implications? How do you internalize that experience, which that's the chronicity aspect. The other aspect is, well, let me switch gears here. But that's the main aspect, is that there's the VA has these evidence-based therapies of which 50% of people cannot complete and do not benefit. So the VA's looking for other therapies at this stage. And so anybody know the importance of March 1st, 2011? Where were you on March 1st, 2011? No, nobody. Craig? No? No idea. No idea. Well, why would you? Okay, because this is this is the date of a release of a request for applications from the VA. So I wouldn't expect you to, unless you troll the sites for these, which some people might, at that stage. Anyway, so this was a remarkable RFA, clinical trials of meditation practices for treating PTSD. And just to give you the perspective on this, as you know, the U.S. military has actually been very active in the use of alternative, or CAM, complementary and alternative medicine strategies for maintaining force readiness and force preparedness, and they have resilience studies involving meditation and things like that. But for some reason, the VA's been lagging a little bit behind. And so this was a very interesting RFA that came out. And they comment about, in the RFA, we provide state-of-the-art evidence-based treatment, but not all patients benefit equally or respond optimally from traditional approaches. This is actually direct from the VA. And so they acknowledge there haven't been many studies of PTSD using CAM, certainly supported by the VA, and it provides an imperative for VA to continue to advance research on new interventions, extending into approaches such as meditation. And the gist of here's the exciting part, right? Someone's groaning in the front here already. Okay, March 4th, 2011, okay, and the due date is May 11th, 2011. So let's see. April 4th, May 4th. This is like 9 weeks. Now, would you apply for a 9-week RFA? How would you feel about applying for a 9-week RFA, Carol?
I would do it, but it would be...
It'll be hell. It would be hellish. It'll be hellish at that stage. Anyway, so the RFA, just some details on this RFA, not intended to support proposal examining meditation as an adjunct to traditional therapy. So they don't want to see it on top of medication. They don't want to see it on top of exposure therapies. They want a straight trial, clinical trial of the meditation as a primary treatment. Okay, as they say, to focus, and clinical trials focus on standardized meditation-based interventions for PTSD, proposing use PTSD clinical outcome measures. And they were so specific in this RFA, they specified what scales they wanted, and what were the criteria for entering the study for the patients, things like that. So they're very, very, very explicit about that part, which made the grant so much easier to write. Anyway, so let's touch talking a little bit about meditation. So meditation, I like this definition that I found. Meditation is a practice. Practice is an important word here, okay? Because practice means, when you hear the word practice, what is the time scale or frequency you associate with practice? Daily practice or things like that. It's like, when I'm talking with when my kids were young and when they were supposed to be practicing for their musical instrument lessons, things like that. It's not like practice half an hour before you leave for the lesson, right? Type of thing like that. Okay, but what's that? You thought, okay, that was part of the advanced Betty Crocker homemaker lesson plan at that stage. So anyway, but it's a practice in which an individual trains the mind or induces a mode of consciousness. And so this is kind of a very general kind of description that hopefully we can put a lot of things. Now, as you know, one of my main points for the talk is not all meditations are the same. We can, just like not all psychotherapies are the same. They have different approaches, different strategies, different theoretical but really our meditations come from Eastern traditions, whether they be Buddhist, Vedic, Tibetan, and they all developed because of different goals, right? They involve different cognitive processes because meditation itself involves somehow the actual brain and what's going on in the brain, and how generally the way we interact with our brain is through our thinking processes. Is that generally how people do it? That may be just my own personal experience. Anyway, and amazingly enough, different meditations have different effects on the brain that can be measured, for example, on EEG. So there's a paper that I like by Travis and Scher that describes 3 general categories of meditation that I think is a helpful heuristic, okay? So one type of, so focus attention, open monitoring, and automatic self-transcending. So let's start off with focus attention. And the focus attention one is the ones you may read about the meditations where they are talking about the infamous candle, right? The candle or the breath or things like that, and or a mantra, okay? And the attention is drawn to that piece, and that's the actual cognitive process. And this actually produces, in practitioners, specific EEG changes in gamma frequencies and beta 2 frequencies. Another type of category of meditation is this open monitoring, in which, and this is really what we actually studied in this particular study I'm going to tell you about. But it is the dispassionate, non-evaluative awareness of ongoing experience. And so the idea is that you experience what's coming in, whatever thought's coming in, and you just experience it without evaluation, without judgment, and it comes, and then you let it go, okay? And we'll see how we try and connect this with the PTSD perspective. And then there's this automatic self-transcending, and so it's described as the automatic transcending of the procedures of the meditation practice. You may say, what is that, okay? Well, and this is an important distinction because people sometimes get confused because since TM involves a mantra, people connect it immediately with focus attention, okay? But in focus attention, the cognitive process is on attention just on the mantra, whereas in TM, the process is to use the mantra to experience finer and finer levels of thought, okay? Finer levels of thought until there is no thought, until there is no thought. And you may say, well, does that mean you're asleep? And you're not asleep, okay? You still have full awareness, but you're experiencing no thought. And how many times do we typically in a day experience no thought? Kind of never. So that's why. That's what makes it a unique experience. Okay, and I failed to mention this open monitoring also has characteristic EEG effects, as does the automatic self-transcending. So these are 3 general classes of meditation. Now, let's think about how meditation may have impact theoretically on the various symptoms of PTSD. So on the re-experiencing front, perhaps learning to accept thoughts reduces level of distress due to intrusive thoughts. But let's think about this from the perspective of the mindfulness piece. So people have these thoughts, have this experience of these thoughts, and what's their typical reaction? So let's say have a flashback. They react to it, right? Gosh, this is terrible. It's happening again. I'm going out of my mind, these things like that. And so part of the mindfulness training then is to change how you experience and process that thought, or those thoughts. In the area of avoidance and numbing, the idea is to encourage approaching. So if you now have a tool that if you do have the thought or you do have the experience, you're no longer trying to push it out. That means you have greater ability to accommodate that, and so perhaps the avoidance will decrease. And then there's the hyperarousal, hypervigilance, and there's evidence that obviously mindfulness practice and other meditations can affect brain regions involved in fear response. So that's kind of our criteria of how we might connect the two. George Romuto has hand up, and I'm trying to decide whether I should acknowledge him at that stage. George, yes. Should I bring a microphone to you?
Kelvin, this is the anti-exposure therapy.
Really?
Yes.
Why is that?
Because you've eliminated all the thoughts. Some of them were traumatic thoughts. They're gone. It's no exposure. It's anti-exposure.
This is the TM one. The TM one was where you go to no thoughts. The mindfulness is the thing. So they're different.
Manage the thoughts that you have.
But
right. Better would be no thoughts.
Could be. Yeah. What a great idea. Thank you. Thanks for answering that point like that.
We figured this out.
Thank you, George. Okay. Okay. So where were we before George? Okay. So we're talking about the potential connections between the meditation and the PTSD symptoms. So I'm just kind of giving you the evolution of how this all happened, because it all happened in 9 weeks, the application, remember? Okay. So this is from a email from Greg Lamberty about meditative techniques RFP. Interestingly enough, it came out on February 28th, 2011, so it made me a little suspicious. Because why is that? Timeline, things like that. But space-time continuum things, things can get, a day or two here and there, like that. Anyway, so basically, there was a meeting called to talk about this application. Just to give you background on this, at that point in time, and there was a preprint, or actually a abstract on Kearney's work, which got published in 2013. There were basically only 2 published studies of meditation specifically in veterans. 2, only 2, okay? And this one described was in MBSR versus treatment as usual in 47 veterans. No effect on PTSD in their analysis, but they acknowledged theirs was underpowered. And Brooks did a study published in 1985, where he compared TM with treatment as usual in 18 veterans with post-Vietnam adjustment. I guess the whole description of it wasn't that out, and he got improvements in PTSD symptoms and depression. So that's the layout. That's kind of the background of what's available for veterans. So, countdown, you have 8 weeks, right? What do you want to do next? These are some of the, so this is the punch list we came up with that stage. One is locate meditation programs present at the Minneapolis VA. Like, has anybody done this yet here? Do we have an experience doing this? Because what's the most important thing you need to demonstrate when you're writing a grant application? What's the most important thing you need to demonstrate? Feasibility. Feasibility. What does feasibility mean? It's kind of the chicken and egg problem, right? Feasibility means, Dr. Wozniak, what does feasibility mean to you? Access to population, okay. Right. Anything else?
No, I think accessing the population, having personnel in place to do the therapies, etc.
How about pilot data?
That would help.
That would help. And basically, you need the pilot data showing that what you propose to do works before you actually carry out the study, right? That's oftentimes the quandary we face, right? You don't face this quandary?
All the time.
Okay, I just want to make sure I'm not the only person who's kind of caught in this approach. Anyway, and then we needed to find the clinical populations, the access to populations, and the expertise with the populations. And then you need a PI who's willing to lose 2 months to this endeavor stage. And so it turns out we had a psychologist, actually John Billig at the VA, who'd been doing introduced mindfulness in some groups about 13 years previous. And then it was taken over by John Rodman, who in the past 3 years had been conducting patient groups, clinical groups, and had been actually collecting surveys, questionnaires in the purpose of what? Quality assurance, quality improvement, right? And it collected all these scales, including PTSD scales, mindfulness scales, and had amassed. So he came to the meeting, and I said, so where are these data? And he said, they're in a pile on my file cabinet in my office. So what's next? You got to enter this data, things like that. And so I was fortunate. I said, but he said, it's not entered, and I don't know how we could get it entered. I said, we'll come down to your office, John, and we carted off the pile of paper. And I have a great research team, and they entered all the data. And then we called Paul Thuris, who's our statistician, and within 5 days, Paul informed us we have a result. You know, this is within subject analysis, right? Because it's not a controlled study, but within subject, we have a whopping effect here, and people who we have the PCL on that stage. So we kind of have feasibility, right? Because we're already doing it at the VA. We have actual result. We have stuff that helps us power the thing as well. So that was, things are marching along, right? Okay, but we're still facing this problem. We don't have a PI. And what are the qualities you need in a PI for a successful application? What do you need for a PI? Availability? Okay, this is good. Other ones? Track record. Other ones? Expertise in the subject, right? Expertise in the subject. Right. Okay. So we're alluding to this part. Building 68 at the VA is the location where the research offices are. It's really how would I describe it? It looks like a temporary building, but it's permanent. Anyway, but Melissa Paluzny and Chris Urbis, who are really our premier PTSD researchers, are there. And so a group of us went to go talk with Melissa and with Chris, and Melissa told her what we're thinking about it. Here's this RFA. She said, well, I've never done work in meditation, things like that, and I'm really very busy. But I'm willing to give you 2 pages of text explaining the importance of PTSD to the VA. And what do you say when someone says something like that? You say, thank you, exactly. I learned to be polite. I said, thank you. But there's another back end of that story. And we thought since we actually have findings, we thought we'd also include EEG work. And so we brought on Scott Sponheim, who's a long-term collaborator of mine who does work in EEG. And so we kind of had the team at that point, except we didn't have the PI at that point. And to make a long story short about the PI piece is that when we started running through the list that we already started, right, in terms of familiar with material, track record, what was the other one? Availability, things like that. We decided to settle for 2 out of 3. We decided to settle for availability and track record, and I was selected to be the PI by our merry group at that stage. So, which was a kind of an interesting experience for me. Anyway, let's switch gears to mindfulness-based stress reduction, because we decided to go after MBSR because we already had experience delivering this, and that was our preliminary data on. How many people are familiar with MBSR? Okay, so now we're going to sit down and we're going to do a body scan, and we're going to. No, we don't have time for that. I'm sorry. I'm way over. Okay. So we had experience delivering this, and we have expertise in the Center for Spirituality and Healing, right? And so we had trained folks who could deliver this. I already told you a little bit about mindfulness, non-judgmental awareness. And MBSR is a standardized, manualized program, 8 weeks, weekly meetings, week group meetings, 2.5 hours roughly. There's also one full day retreat. There's a complete curriculum. There's homework, the readings. It requires a fair amount of work, right? Okay? And basically, in terms of techniques, it provides instruction in 3 formal techniques: the mindfulness meditation, body scanning, and also some yoga postures. So our clinical trial, we decided to do a randomized controlled trial design. This is a standard intent to treat analysis. And we were going to compare MBSR to present-centered group therapy. Why would we do present-centered group therapy instead of treatment as usual, as others have done? Well, one of the reasons for this is that going to treatment as usual, there's a methodological issue, right? Because people in the treatment as usual aren't getting the same attention, so to speak, and they aren't spending time like the folks in the MBSR group. And so we needed to balance that in terms of attention and effort. And it turns out the key clinical trials done by the VA, funded by the VA, actually use present-centered group therapy as the active control. Because those of you who've worked in the VA know that veterans love groups. They just love groups, okay? And so providing a clinical trial where you can say, you can either be in MBSR or in PT or in a present-centered group therapy, and they say, oh, both sound good to me, okay? MBSR, we use the Kabat-Zinn's curriculum. We had a manualized group therapy that's been published that's been done in clinical trials. The patients had to meet PTSD criteria, and the patients were assessed using self-report, clinical interview, whole set of measures that are summarized here at this stage. And I'm only going to deal with a few of these in describing you the results. But let me say, if you were to, we're talking about the kind of process at that stage, because it resulted in a set of meetings that were happening. And when you have 8 to 9 weeks to prepare a grant, and let me think, oh, that last week I was traveling. Where was I? Unfortunately, I was in the continental United States, but I was in San Francisco at what meeting happens in May? It was just before the EPA. It was the biological psychiatry aspects, things like that. So I was away, but I was in constant contact, right? And turns out, just to turn around the story with Melissa, Melissa ended up pulling 2 all-nighters working on this grant. Okay, and so she provided much more than 2 pages. I just want to start, but it was really a tremendous experience bringing together a team like that to work on between our PTSD expertise, the folks working with MBSR, statisticians, EEG, to put together this thing, and actually to do it fast. The shorter deadline actually made it more intense in some way. Well, why not? Okay. Anyway. 32 applications for this RFA, 3 grants funded, and we were one of the 3. And what came out in terms of the reviews is what we all know, is that the fact that we had preliminary data, we'd actually implemented it, we had data collected our VA was a key part. This is a sort of modified consort diagram that many are familiar with who do clinical trials. But basically, we ended up randomizing 116. You can see the challenges in terms of screening people and baseline eligibility. And we had evaluations done. Main evaluation was at 9 weeks and 17 weeks. And we also had other data points during the actual treatment phase. Here's the main results slide. Red is the MBSR. What color is this? I can't tell. Is it olive? Is it olive? Okay. Olive is PCGT. Okay. What's the first thing you notice here? A baseline? Yeah, there was. And it shows you that straight randomization sometimes doesn't work, okay? And we had a problem that we didn't do the randomization based on stratification of severity. But this is an important point, okay? So what else can we draw from the slide besides this part, okay? Here's the MBSR group, okay? Here's the PCGT group. What's interesting here? It went up, right? Kind of went up. And so we were puzzling about this and about PCGT, and we said, well, why would it, after a couple weeks of group therapy, that people's symptoms would increase in a group therapy setting? What's that? You're bringing up the trauma, the experience, things like that, and that's kind of what we thought as well. Anyway, these are the between group change p-values here. And what this is saying is that by week 6, compared with baseline, okay, not the different, but compared with baseline, there was already a significant difference between groups, okay, such that MBSR had greater reduction in symptoms, right? And this held out all the way out to 17 weeks. Any other things you'd want to say about this slide? Yeah, they do seem to be, and this. Exactly. It's a change from baseline. I mean, optimally, you'd want these to be identical, but they aren't. But so this is tied into the actual analysis piece. Okay. So this is PTSD, but this is self-report. PCL is a PTSD checklist, so it's a self-report scale. If you look at interview based on CAPS, based on an actual patient interview using the CAPS severity score, we have a between group effect difference at the 2-month point. So here's the depression based on a PHQ-9. How many people love the PHQ-9 for depression? Okay, we'll skip this slide, okay? No, but basically we got a borderline kind of, trend-like thing. PHQ-9 is probably not a good instrument for looking at depression. Suma.
I know MBSR has a very standardized protocol for the clinicians, but for your PCGT, where the people, I know the content can vary quite a bit based on the group. How standardized were the clinicians administering it, and does that attribute for some of your variability?
So the question is of how we know MBSR is very standardized. What about the group therapy? The group therapy is actually a manualized one, okay? And we actually had a external consultant, Michelle Wattenberg, who developed this, was on weekly, no, I think it was every 2 weeks, they were on conference call reviewing what was happening in terms of process. The other part, so you know, as part of the actual study, is that all the sessions were recorded, both the PCGT and the MBSR, and then 10% of those were randomly selected for complete review to check for fidelity of the actual treatment aspects. And the data showed that we were able to deliver them with high fidelity. But that's an important point, because you'd think the PCGT would be a far more kind of open type of approach. Okay, so we weren't going to talk about this slide. This was something that we, besides the PCL and the PTSD, the overall PTSD symptoms aspect, was one of our most intriguing results. Okay, so this is quality of life based on the WHO breath quality of life scale, okay? And higher scores, better quality of life, okay? So here we start pretty close, right? I'm sorry, I'm already switched here. Quality of life, pretty much stay here. And immediately post-treatment, we have a trend difference here. And then we have a significant difference, between group difference of 2-month follow-up. I'll share with you that we were invited, the investigators were invited to, on August 4th, to come to central office of the VA to present to their R&D, the Research and Development Group, and their Office of Mental Health about our study. It turns out we presented there on August 4th at 4 p.m., and the paper was removed from embargo at 11 a.m. that morning, kind of thing. So it was kind of interesting timing. Did you want to know more about the? Yeah.
The other thing that's striking is MBSR is really a skills training program in addition to therapy, where PCGT is really more therapeutic than skills training. So this is sort of in my ideal scenario, you would have a follow-up study where you would actually test it against a skills therapy. Because you expect them to maintain skills they can use in their everyday life with new stressors, whereas with a group therapy session, you have interpersonal skills that don't generalize and aren't as concrete.
So one analogy is that instead of feeding people fish, we're teaching them to fish, right? And I think that's one of the very interesting things that was pointed out by the people they were very interested because they're interested in these chronic disorders, not so much about what can be done on the symptom front, but on the quality of life aspects. And this what we found was that the quality of life ratings dropped after the group therapy people stopped, but it stayed pretty much constant for the people who were in MBSR. So implying that they learned something. And when we done interviews with the veterans afterwards, they said, "Oh yeah, I do that all the time. You know, I what you taught me in this group." They've come to me to tell us that. Oh, mindfulness skills. Okay, so the colors here are really it's one of these discrimination tasks. Okay, can you tell the difference between who can tell the difference between this color and this color? Okay, so about 40% won't get the slide, so it won't matter. Okay, let me try and take you through this. So this is, do I have this color right? This is the MBSR group, right? Does this make sense? So the MBSR, they start like this, and then by 6 weeks, their mindfulness skill, self-report, has increased. Okay, and then it goes up to here, and it stays constant. And what happens with the mindfulness skills for the PCGT group? Nothing. Anyway, it turns out the mindfulness skill change is highly correlated with and significantly correlated with all our symptom measures. Do you have a
demographic slide. I'm wondering what your participants like sex, age, any of that stuff matters.
You know, I missed that slide, sorry. But we can talk about it later. Or I can refer you to the paper, and I'll refer you to the published article in the August 4th issue of JAMA. Okay, anyway, but I should have that, thank you. And so this is just the last part in terms of comparison of effect sizes of our mindfulness trial compared with exposure therapies. So I focus on this number here, between group effect size. Okay, this is from the Ptsd paper, Ptsd et al. Paper. This is the JAMA paper. So we had in our study an effect size of 0.4. This is a study of CPT, cognitive processing therapy, versus not a group therapy, but a cognitive therapy group. Okay, and the effect size here is the same. Okay, and then here's a study, Paul-Schnur, prolonged exposure therapy. also 0.4. What's the dropout here for this study? High, about 40%. And for us, we were at about 20% dropout in terms of the MBSR. So pretty similar effect sizes across, comparable to that of the exposure therapies. So let's see, next steps. This is published in JAMA, and we can get you for it. We have other data that needs to be analyzed when you have a, so just to give you the background on this, we were given 2 years to do a full randomized clinical trial from start to finish, and only $1 million do that. Anyway, so it was kind of frantic. But we have other data, including serum biomarkers, we have DNA, we have EEG data. We need to think about the next study that we need to do whether it could inform clinical practice. You know, could be multi-site or a VA cooperative studies grant. This is kind of my summary of my points that I described earlier. And this was a big team that carried out the study, including my co-investigators here, our study staff, lots of people in supporting roles. We had PCGT and MBSR group leaders, and we also had the consultants. Here's Melissa Wattenberg about the Presence Center group therapy, and we also had help from the Center for Spirituality and Healing. And I'm at 11:57, so I'm going to stop talking. Good. Question? My head was blocking it?
No. Somebody's sitting in front of me here.
Who could that be?
The clinician ratings of the PT of the I don't know what's it called, the scale, not the PCL but the CAPS.
CAPS,
yes.
Yeah.
So the effect size was about half of the self-rating, PCL rating. So how do you interpret that? The objective rating, the effect was not as great as.
We see that at times. You know, in the CAPS difference is sometimes different than the self-report things, and it's an interesting question of what is the more important part in terms of what is it that the patient's experiencing versus what we objectively try and measure and try and get into their head about what they view their symptom issues. It's a commonly seen effect. Other questions? Sasha.
I'm just wondering if you've thought about doing booster sessions for the skill maintenance piece.
I think that's the key piece as we think about next level studies. I mean, the veterans are asking us for some type of weekly place that they can get together and practice together. And I think it's coming back to meditation as a practice. You only benefit from it if you practice. Okay, I think that who comes into us afterwards? The pediatrics people. So we better.
One last question. Do you have one more question? Okay, everyone, I want to say thank you one more time to Dr. Lim for this really fantastic presentation. Thank you.